Okay, hi everyone. So welcome to this session of the Philosophy of Psychiatry webinar. Today we are very pleased to welcome Awais Aftab, who is a clinical assistant professor at Case Western Reserve University and attending psychiatrist at North Coast Behavioral Healthcare in Ohio Department of Mental Health and Addiction Services. Awais Aftab leads the interview series Conversation in Critical Psychiatry for Psychiatric Times, which explores critical and philosophical perspectives in psychiatry. He's also a member of the Psychiatric Times Advisory Board and a member of the Executive Council of the Association for the Advancement of Philosophy and Psychiatry. He has been actively involved in initiatives to educate psychiatrists and trainees on the intersection of philosophy and psychiatry. And he is also the author of many papers published in well-known philosophy and psychiatry journals. So I'm very pleased to give the floor to Professor Awais Aftab for a talk entitled Disorder and the Legitimacy of Medicine.
Thank you, Anne-Marie, and good afternoon, everyone. Let me pull up my slides. Okay, and that's showing up okay? All right. So this is the title of the talk today, Disorder and the Legitimacy of Medicine. And just a quick shout out to AAPP, Association for the Advancement of Philosophy and Psychiatry. It's a group. It's a very multidisciplinary, interdisciplinary group that's focused on philosophy of psychiatry, and it's sort of like very active and robust. And I just want to sort of like put it out there that if there are people who are interested in being more engaged with the scholarly community in this area and looking for some place to start, AAPP is a good venue, and I would encourage you to look it up and consider becoming a member. And we kind of went over my bios. I won't repeat that. One thing I will say is that I am fairly active on Twitter, and I usually sort of like post a lot of stuff there and participate in very kind of discussions. So if you're interested, feel free to follow me there. So let me contextualize my talk a little bit today and give you a sense of what's the background and what direction I'm trying to take. So in this talk, I examine the implications of treating disorder concepts, including less pathologizing alternatives such as medical problem or medical condition, as a way of referring to our current historically contingent domain of medicalized distress, disability, risk, harm. So basically sort of like this messy heterogeneous sort of like area that we have currently medicalized, that is currently under the domain of medicine, whether you want to call it something like a medical problem, medical condition, or whether you want to use something more specific like disorder. So I'm going to sort of like look at that from a little bit descriptive perspective and this sort of like historically contingent perspective. And then I want to discuss the issues this poses for the question of legitimacy of medicine and what offers justification for medical care. And my discussion is set both in response to radical critiques of disorder concepts offered, for instance, historically by Zaz and presently by the UK critical psychology community. And it's also a critique of medicine's rapidly expanding domain, kind of like addressing concerns of over-medicalization. And it's my impression that a common strand in philosophical discussions, like both among those who criticize the medical status of psychiatry, as well as those who defend it, is the notion that the justification for medicalization comes from a valid notion of disease or disorder, that sort of like somehow this concept provides us with the foundational justification. And if we can sort of like either defend it or critique it, we can make our points. And this is not always articulated, but based on my reading of the literature, it appears to be in the background quite a bit. It's implicitly there, even if it's not explicitly present. And I hope to show how a philosophical focus on the definition of disorder, and here sort of like I'm talking sort of like generally about medical disorder, but also sort of like, including mental disorder, as providing us with a foundational justification for the legitimacy of medicine is an error. And then if we sort of like, if we question that, and if we sort of like decide that, disorder doesn't sort of like provide any such justification, then this legislation of like, where does the justification come from? And so we kind of like, I'll talk a little bit about sort of like what my understanding and my approach to this question is. And particularly because understanding the nature of this justification allows us to revisit the criticisms and defenses of psychiatry. One thing I'll say is that I'm not a philosopher by training. I'm a psychiatrist. I'm primarily a clinician, sort of like with some involvement in academia. But I have one leg in the philosophy of psychiatry sort of like arena, and I participate in the discussions, and I'm a member of this community. But my thinking primarily sort of like is very informed by the clinical work that I do. I know that we have a very diverse audience as well. And so with that in mind, I've tried to keep the talk simple and accessible, but it's still primarily focused on these abstract philosophical questions. And I'm also sort of like not presenting any sort of like a roadmap or a solution for like how healthcare like should be like. I mean, that those are sort of like obviously very interesting questions to ponder, and there would be implications for that. But if you're coming to the talk with some idea that I'm going to be like presenting some grand solution to the mess that is our sort of like healthcare system and psychiatry and medicine, that's not going to happen. But hopefully we can sort of like be informed by some of these general abstract considerations. Another thing is that what I'll be discussing in the talk today, it's informed by some of the earlier work that I've done, particularly sort of like in these two publications. There was a series of articles that I wrote for Psychiatric Times. This was based on my Jaspers Award paper for AAPP, and was sort of like looking at social misuse of disorder designation. And then there was a recent paper came out last year for International Review of Psychiatry on the topic of mental disorder and social deviance. And we were basically looking at philosophical strategies that can help us differentiate between the two, and to what extent can this differentiation even be successful. And so a part of this, the earlier work has resolved around sort of like issues of naturalism, sort of like naturalist concepts of mental disorder, as well as sort of like ideas like to what extent any notion of disorder is influenced by values versus to what extent could be objective, etc. I'm not going to go into those specific debates. They are kind of in the background for me, and they do inform the things that I'm saying, but I don't directly refer refer to them or sort of like deliberately bring them on. In fact, I'm sort of like there's not going to be any reference to Wakefield or Bohr's in this lecture at all. I feel like we've all kind of rehashed those debates quite a bit. And so this kind of like presents an update of sort of like how my thinking has changed over the years. And instead of sort of like being focused on the notion of disorder by itself, I've started thinking about this broader idea of domain of medicalization and the sort of like, how do we justify that? And so my hope is that we can sort of like take a fresh look at that and maybe break some of the stalemate that has existed in the literature so far. And if there's anything that you feel sort of like doesn't make sense, we'll have a lot of time for discussion at the end, and so hopefully we can have a pretty healthy Q&A. So let me sort of like start by quickly recapping like the traditional sort of like Zazian argument, and not sort of like in order to like analyze in detail, but primarily to sort of like show the structure of that and how it sort of like invokes this notion of disease or disorder. So Zaz, in his 2011 paper, he kind of like recaps what his central argument has been, and he says, my claim that mental illnesses are fictitious illnesses rests on the pathologist's materialist scientific definition of illness as the structural or functional alteration of cells, tissues, and organs. If we accept this definition of disease, then it follows that mental illness is a metaphor. I suggested that we discard the traditional psychiatric perspective and instead interpret mental illnesses and psychiatric responses to them as matters of morals, law, and rhetoric, not matters of medicine, treatment, or science. So for Zaz, like, his particular definition of disorder, illness, disease is playing a very crucial role, because if Zaz thinks that I define disease in this way, and whatever gets excluded from this definition, therefore is not under the domain of medicine and is under the domain of morality and law and other things, it's not a matter of medicine. So he sort of like sees sort of like this definition as a very foundational thing. And if you look at the classic responses to this sort of like Zazian critique, they have taken the approach of like defending an alternative view of the notion of disorder, one that invokes ideas of suffering, impairment, distress, risk, harm, etc. So this is, for example, like Ronald Pies writing in 1979 on the patient-centered or phenomenological view, schizophrenia, as well as such entities as idiopathic epilepsy and migraine, may be considered a disease because it entails suffering and incapacity, albeit in the absence of any obvious lesion. The presence of substantial and or enduring suffering and incapacity in the patient, arguably the hallmarks of disease, as commonly understood throughout the long history of clinical medicine. And then sort of like in another article that was co-authored with Mark Ruffalo, historically, the concept of disease has always been more intimately tied to the degree of suffering and incapacity experienced by the individual person than to demonstrable biological dysfunction. And so it's sort of like, so it's saying this response kind of like has an insistence in the other sort of like way. They said, well, there's this other definition that is sort of like very historically respectable, that is based on sort of like ideas of suffering and incapacity. But sort of like this also suggests that there's an implicit acceptance of the idea that it is the notion of disorder that confers legitimacy to a medical response to the condition in questions. And I'm sort of like, I'm increasingly skeptical of that. Another thing is that a central element of the rhetoric of psychiatric expansion is an assertion that the condition is a disorder, and we're sort of like seeing it kind of like unfold in real time, as well as like recently, for example, when prolonged grief disorder was formally introduced into DSM-5. So Psychiatric News sort of like reported it in October 2020, and as part of that story, there was a quote from Ken Kendler, and sort of like he said, there's substantial evidence that the proposed category would meet criteria for a mental disorder. And then sort of like the story says, Kendler told the board that studies dating back several decades suggest that many people experience persistent difficulties associated with bereavement that are substantially prolonged beyond culturally sort of like normed expectation. And then sort of like, this is like a Psychiatric Times article. This is from like the October 2021 issue. It kind of like focused on video game addiction. It's kind of like, again, sort of like this grand question of like, is this a disorder? Because seemingly sort of like determining whether it is a disorder or not sort of like, gives us the authority or legitimacy to kind of like, make it a medical problem or a psychiatric problem. So again, sort of like we see there's like popular, as well as I think I would say general philosophical discourse, quite focused on this notion of establishing whether something is or is not a disorder, as if sort of like establishing that provides the central hinge on which sort of like everything else evolves. So that's the sort of like setup. So taking a step back, there's a recent book chapter that I worked on with Peter Zakar and Conrad Baneke. It was on historical and philosophical considerations in studying psychopathology. And one of the things we were looking at, descriptive versus conjectural approaches to psychopathology. And at one point in that chapter, we write, the more agreement there is on the background theoretical assumptions, the less disagreement there is on what is being described. This suggests that what are considered descriptive approaches to psychopathology are approaches where there has been comparative agreement among multiple parties regarding the background assumptions. So, when we look at controversies around disorder concepts, disease, sort of like, illness, medical condition, I feel like there's also this tension between description and explanation. Critics believe that these terms are loaded with explanatory content that they do not agree with. And so the more disagreement there is on these background theoretical assumptions that are not shared by various parties, the less agreement there is on what is being described. So I've been kind of thinking about like, so in what way could we approach sort of like this notion of disorder, this notion of medical problem, in a way where we're making sort of like these background assumptions in a minimal way, or at least in a way that would be like shared among different parties. And so when it comes to disorder concepts, how can we have descriptions that have minimal explanatory content and as much theoretical agreement as possible? And I think one of the ways we can sort of like do that is by looking at our sort of like current historically contingent domain, that this is sort of like, these are the conditions that we have sort of like medicalized so far. This is what we are dealing with, and without necessarily making any assumptions of like, what is the nature of these conditions, or sort of like what is the justification, like what's going on with this, what's going on with this domain, if we try to sort of like take a descriptive approach to that. And if we do that, sort of like we see that there's sort of like, at the moment, at least, there seems to be sort of like an interplay of like sort of like these two large elements. So there, and both of them are quite broad and fuzzy and vague by themselves. So this is by no means something sort of like very specific or objective. So there are sort of like there are various sorts of like notions of distress, disability, harm, and risk, like very expansive kind of category. And then there are all sorts of like vague and fuzzy notions of abnormality, and sometimes these are folk psychological notions. It's could be sort of like attempts at more scientific notions, which could be like attempts at a natural sort of like kinds, or sort of like more specific biological dysfunctions. So it's a wide variety of views on what sort of abnormality might be there. And I think when we sort of like look at particularly the area of psychopathology, so we're looking at all of like medicine and all of medicalized domain, but especially in the area of psychopathology, the folk psychological judgments appear to be quite predominant, because most of the conditions that we currently call psychiatric disorders, they're really sort of like they're kind of defined by these sorts of folk judgments of whether the behaviors and experiences are unexpected or unfamiliar, they're not easily intelligible, they're disproportionate in reaction, excessive in some manner, they break the rules of social conduct, violate norms of shared rationality, not subject to ordinary expectations, etc. And then sort of like, in addition, they tend to be distressing, disabling, harmful, or associated with some sort of perceived risk. So this is a diagram, sort of like, I'm trying to sort of capture some of my thinking. So the blue one here sort of like represents the domain of distress, disability, impairment, risk, harm, basically sort of like any sort of like any of these related concepts that could conceivably be medicalized. So that, so it's like something that you could think that could be medicalized at any point in the future, or in any sort of like any other possible world. Versus sort of like, here, this is the domain of like, distress and harm that is medicalized at present moment in our particular history. And as you can see that, this is not a smooth circle, the edges are uneven because the boundaries have been determined by folk psychological judgments of abnormality. And the domain has expanded by a peculiar, idiosyncratic, historically contingent logic without a unifying principle. And this by itself is a fairly sort of like well-recognized kind of observation. So, it's very good. People recognize that our current domain of disorder as well as medicalization is quite heterogeneous. It seems to be governed more by family resemblance rather than anything else. Alan Francis has called it a hodgepodge. Peter Zacher called it an imperfect community lacking in essence. And Jennifer Radin called it incoherently arbitrary and diverse. So I can agree with that. So that there, whatever sort of like our current domain is, there isn't any straightforward unifying principle behind it. It lacks in essence. And the task of justifying our presently drawn boundaries of this domain in terms of a unifying principle, I personally feel at this point it's a hopeless task. So why do we insist so much on justifying our presently drawn boundaries by invoking notions of sort of like health and disease and disorder? And I feel there are two impulses behind our contemporary notion. Sort of like, so one is that we wish the notion of disorder to provide us with safeguards against unwarranted medicalization. We wanted to provide us with a line that cannot be crossed, something that will sort of like, curb the tides of medicine's encroachment. And then sort of like the second thing is that we want the notion of disorder to provide a justification for medical care, that sort of like there's this idea that medical care is necessary or warranted for condition X because condition X is a disorder. Sort of like this idea, this almost like truism sort of thing, medicine treats diseases, right? So if you can establish something that is a disease, then medicine will treat that. And so what grants medicine the authority to treat a problem is the disorderedness of sort of like of that problem, or the disease attribution of that problem. And I think both of these aims and goals and impulses are fundamentally mistaken. I don't think the disorder can do either of these things. Obviously, I do think there are some sorts of safeguards against unwarranted medicalization, and I do think there's some sort of justification in medical care. But I don't think that either of these things come from the notion of disorder, or sort of like, from sort of like more general sort of like concepts like medical condition or medical problem. So another thing is that to imagine a different medicalized domain and a different concept of disorder as enacted in clinical practice, we have to imagine a different society with a different relationship to healthcare. So as an example, before 1962, medications rarely had a prescription-only status. After 1962, most medications had to be FDA approved for specific indications, and they had to be prescribed by physicians for specific indications. And this sort of like, we don't appreciate it, but this led to a significant sort of like reshuffling and rearranging of sort of like, of our collective relationship with this notion of disorder and sort of like this notion of disease. So David Healy in his book Pharmageddon writes at one point, it seems extraordinary now that no one in 1962 seems to have realized that if pharmaceutical companies were restricted to marketing drugs for diseases, they might start to market diseases. Had pharmaceutical companies not been required to demonstrate a drug's efficacy in treating a particular disorder, we might all have ended up with a lot fewer diseases recorded in our medical records. The first antidepressants would have been marketed as tonics or stimulants. To get St. John's wort, a herb with SSRI properties, we just have to feel stressed and buy it over the counter where it is sold as a tonic. But to get Prozac now, we have to be officially diagnosed as depressed. So sort of like the historical forces changed in a way where our relationship with sort of like, what we consume in terms of medicinals changed in terms of like what is required for us to do so. And such historical forces shape our domain of medicalization far more than any definition of disease concepts. So talking a little bit about sort of like, justification. So disorder attribution appears to be invoked to provide a justification of medical authority, but does medical authority really rest on the concept of disorder? Perhaps it gets the order of things wrong. Calling something a disorder does not justify or authorize medical assessment and medical care. Rather, calling something a disorder is, in one sense, an expression of the judgment that a condition has already been deemed to be appropriate for medical assessment and care based on XYZ independent reasons. And it is those reasons that are the appropriate targets of philosophical and scientific scrutiny. Historically, judgments of pathology have played an important role in our notions of health and disease, but it is clear that the scope of modern medicine extends far beyond judgments of pathology to include a wide variety of states of risk and a wide variety of states of suffering. So this, for example, is from the 8th edition of Harrison's sort of like classic textbook on internal medicine. Sort of like the authors write, the clinical method has its object the collection of accurate data concerning all the diseases to which human beings are subject, namely all conditions that limit life in its powers, enjoyment, and duration. And the physician's primary and traditional objectives are utilitarian, the prevention and cure of disease and the relief of suffering, whether of body or of mind. And again, sort of like, invoking Ron Bai's sort of like emphasis on suffering and incapacity. So he writes in one of his articles that if, as I believe, the broad and overarching goal of medicine as a whole, and psychiatry in particular, is the relief of suffering and incapacity, it would seem that the range of targets for medical intervention is wide indeed. So in principle, if we take that view, the domain of medicine is huge in its theoretical scope, and could be many folds greater than what it already is, hard as it is to imagine. But this also makes it plain that the justification cannot simply come from broad notions of suffering, impairment, limitations, risk, because the domain of suffering is sort of like, potentially endless. It's certainly quite large, and we have only medicalized a small portion of it. And so we have only medicalized a small portion of it because we lack justification at present to medicalize the rest, even though conceivably, in some other sort of like other world, or in future at some point, we could medicalize it. And so justification of calling something a medical problem cannot simply be an appeal to the limitations of life, but the justification has to be on grounds of what medicine can offer. If medicine has little to offer and there are better alternatives, then the justification is lacking. And sort of like, and this sort of like just kind of like lists some of the conditions that are currently kind of like, currently not formally medicalized, but they're all instances of various sorts of harm, various sorts of suffering, various sorts of problems, sort of like risk, impairments, etc. And to some extent, some of these are beginning to be medicalized. Grief, as we see, sort of like prolonged grief, it's not sort of like formally a disorder. Sort of like there's always sort of like these debates going on to what extent conspiracy theories might be different from delusions, etc. But generally, by and large, these conditions, these instances of various sorts of risk, harm, suffering, impairment are not medicalized. And why? Because medicine doesn't really have anything to offer, sort of like what is medicine going to do? We don't sort of like have any, medicine doesn't sort of like possess the tools to address them. Now, it doesn't mean that these tools don't exist sort of like in principle, conceivably sort of like, medicine could develop the tools to address them, but it doesn't at the moment. And therefore it lacks justification to sort of take these conditions on. So at the same time, sort of like, the justification cannot be the presence of neurobiological dysfunctions or the presence of natural kinds, because natural kinds constitute only a small part of the limitations of life. And there are too many bona fide examples of medicine successfully addressing problems that are neither neurobiological dysfunctions nor natural kinds, that the scope of medicine in the present day cannot be restricted to some version of naturalism. And that's sort of like assuming that a naturalist account is even viable. I'm kind of agnostic to the idea. I mean, I think it may be viable. I'm not sure. But even if it is viable, it's the case that the scope of medicine cannot be restricted to whatever the domain of natural kind is, because there are just too many things that are not natural kind and that medicine can successfully treat. The problem is expanded in scope when we consider clinical psychology and psychotherapy. It has been clear in the case of psychotherapy that its application is not limited to those with bona fide disorders. Psychological conflicts are universal. Even the well can benefit. Since mental disorders, in the sense of clinically significant psychological problems that come to the attention of clinicals, so this sort of like, this category is shared by both psychiatry and psychology. The possible domain of this category is even greater than that of medical problems alone, since the justification can not only be offered on grounds of what medicine can offer, but also on what clinical psychology can offer. And this sort of like, brings up the question of like, how do we understand the relationship between the two? So are all disorders medical problems, or are there disorders which may be psychological problems but not medical problems? And sort of like, and how would we determine that? And consider prolonged grief disorder, the newest addition to DSM-5. It is an official disorder, but does that also make it a medical problem? And I think the challenge here is that sort of like, the DSM and the term disorder, particularly sort of like mental disorder, is currently shared by both medicine and clinical psychology. And any boundary between medicine and psychology, or the absence of it, will depend on how the identities of these two professions have been negotiated at any particular moment in history. And it is how that professional negotiation has taken place that will sort of like determine whether something should be considered a medical problem versus a psychological problem, or maybe both at the same time. So this kind of like, shows you a sort of like Venn diagram of this issue, like, are all mental disorders also medical problems? Sort of like, and so one view would be that anything that is a mental disorder is also a medical problem. So you have this larger group of medical problems, and some of them are mental disorders. And then the other view is sort of like, the other thing is that some mental disorders are medical problems, but there are other mental disorders that are not medical problems, and they might be sort of like more psychological problems, as in belonging more to the domain of clinical psychology. And this sort of like, the questioning is not unique. I'll talk about that, but it's another issue is that at present, in some ways, clinical psychology uncomfortably occupies a place in healthcare under the larger umbrella of medicine. So many clinical psychologists are employed by hospitals, have academic appointments in medical departments, work as part of multidisciplinary teams. However, this uncomfortable arrangement is beginning to be challenged, most prominently in the UK. And this protest is being expressed in the forms of conceptual, ideological, and terminological challenges. But in reality, I feel it's sort of like this grand negotiation between sort of like the boundaries of the two disciplines. So, and this is not without historical precedent. So when sort of like DSM-3 was kind of like being developed, Robert Spitzer's, his initial proposal for the definition of a mental disorder in DSM-3 was to define mental illness as a subset of medical illness. That's sort of like there's this larger category of medical illness, and mental illnesses are a subset of that. And this generated pretty strenuous opposition from psychologists. So the president of the American Psychological Association at that time expressed his strong objections, saying that mental disorders without organic etiology had no justification for a medical label, and saying conditions obviously acquired through learning experiences should not be equated with medical disorders. And Maurice Lohr, who was another sort of like representative of American Psychological Association at the time, he said mental disorders as medical disorders should be limited to those conditions for which a biological etiology or pathophysiology could be demonstrated. And the sort of like the protest from American Psychological Association was like to such a degree that the DSM-3 task force kind of yielded on that point. And they created a more agnostic definition of mental disorder, which did not specify its relationship with medical disorders or medical illness. So it kind of like, left that question basically unaddressed. And so there's sort of like, again, sort of like we see this tension between the idea that are all mental disorders medical disorders, and if they are, or sort of like, if they're not, like what's the, like, how do we determine that? And we see sort of like American Psychological Association taking a more like biological sort of approach that, only things with biological etiology should be medical disorders. And I don't think that reasoning by itself is defendable. I think it has its own problem, but I think it highlights this problem of negotiation between the two disciplines. So in a sense, when, for example, you have these recent reports by the British Psychological Society, which challenge the conceptualization of depression or psychosis as disorders or illnesses, it's not really a debate over whether depression and psychosis are distressing or impairing, or whether they may require care or in a professional societal response. Those things are largely, everyone agrees with that. It's a debate over what sort of care they require and what justification medicine has for its current dominance in the care of depression or psychosis. This debate only makes sense to me in the context of an ongoing negotiation between medicine and clinical psychology, and the power that medicine has wielded historically. So, so where does, if the legitimacy of medicine doesn't come from sort of like this notion of disorder, where does it come from? It comes from reasons such as the presence of suffering, impairment, harm, medicine's ability to accurately understand the nature of and treat certain instances of suffering, harm safely and effectively. And there's also, so these themselves are kind of like terms without any like objective description by themselves. These are terms that are themselves negotiated within a sort of like within the norms of a community. And medicine accountability to science and society, sort of like, so sort of there's a certain degree of sort of like something that medicine owes, that, adherence to certain degrees of like scientific standards, sort of like, justifying its practices based on scientific evidence or norms of science, and sort of like, an accountability to society in terms of like ethical norms and its sort of interface with the law, and the social and scientific legitimacy of its professional training. Nothing in this requires that we rely on the notion of disorder or disease, let alone that we rely on a notion of disorder that requires disorderedness to be a natural fact. The discussions tend to get intense because of the perception that the applicability and legitimacy of the medical model rests on whether we call something a disease, disorder, illness, etc., etc. The critics seem to think that they have administered a coup de grace by denying that a condition such as psychosis is a disease by their definition, while defenders seem to think that they have successfully defended the legitimacy of the medical model by establishing that psychosis is one by their definitions. But choosing what definition to employ doesn't really settle anything. So use of disorder as a concept, may still be valuable in some sort of like specific narrow sense. And my argument is not necessarily here that we should discard disorder concept or stop talking about them. But any value that sort of like these concepts offer is distinct from serving the following function: determining the boundaries of appropriate medicalization, rendering appropriate medicalization distinct and mutually exclusive from social deviation, preventing human rights abuses of psychiatry, or offering a philosophical justification for legitimacy of medicine. So sort of like, to understand that, let's think about instances of disorder attribution, where let's say we think something has been mischaracterized as a medical problem. To say that a condition has been mischaracterized or misattributed as a medical problem is not to say that the condition is not in the realm of distress, disability, harm, because that realm is so huge. Not to say that the condition could not be medicalized appropriately in any possible world. It could very well be medicalized in some conceivable worlds. Rather, it is to say that the justification that has been offered for viewing and addressing this condition medically in this particular time and context has not borne out, that the justification has not lived up to its promise. So this is sort of like, so here's an example, sort of like using medically unexplained symptoms. Recently, I was reading the psychiatrist Alistair Sandhaus' book, Head First. And so this is sort of like, these are some statistics from one of the chapters. And so he's talking about sort of like how common it is for in sort of like, especially like in outpatient settings, for there to be symptoms whose like etiology has never sort of like been properly determined. So in the US primary care study, sort of like, that he cites, of over 550 new complaints of common symptoms such as chest pain, fatigue, dizziness, headache, etc. And underlying cause was only found in 16%. Doctors attempted treatment in just over half the cases, and often that was ineffective. In another study in medical outpatient clinic in Holland, only 48% had a definitive medical explanation. In specialty settings in London, sort of like, the percentage of complaints that could be explained medically, that is sort of like, that where they identified a certain specific cause behind that symptom. So it was only 34% gynecology, 38% neurology, 42% gastroenterology, 45% cardiology. So it's basically the norm that in many medical settings, you get these medically unexplained symptoms that you're not able to figure out really what's driving them or what's causing them. And you kind of like attempt some sort of symptomatic treatment, and sort of like, in some cases it works, in some cases it doesn't. And Sandhaus sort of like in his books, it's like is really dissatisfied with our current approach to sort of like to these medically unexplained symptoms. And he expresses this frustration sort of like in this paragraph. I'm going to read it. He says, for many patients, we end up doing them no good at all. And we harm quite a few more through unnecessary medical procedures. We make patients of normal people who don't need to be in the healthcare system. And this is sort of like, his language, that people do not respond to our disease-focused approach is seen as a failure of medicine. And our solution is usually to apply more of it. It is a failure of medicine, but not because we lack the technical abilities to understand the human body. It is a failure to understand people, why they develop symptoms, why they come to see a doctor, and offer a failure to understand what they want from their interaction with healthcare. So this sort of like, this sort of failure that Dr. Sandhaus is identifying, in his word, this making patients of normal people who don't need to be in the healthcare system. It's not something that any definition of sort of like disorder or medical condition can prevent, because what medicine can offer at a particular time and location in a particular history, its success or its failure to understand why people develop symptoms that they do, and what people really want from their healthcare, is not something that can be captured or tracked adequately by any definition of disorder, medical problem, or medical condition. So I think this sort of like, opens up sort of like to considerations of pluralism as well as standpoint epistemology that I'm going to briefly touch on before I wrap up this debate. So this discussion. So a focus on what medicine has to offer opens up sort of like pluralism and standpoint epistemology. So for pluralism, from a perspective that a medical problem is not just a medical problem, because this characterization of the problem as medical is not something intrinsic to it. A medical problem can also be an interpersonal problem, an existential problem, a problem of living, a spiritual problem that may be addressed successfully by non-medical intervention. So within this context, the medical perspective is simply one way of conceptualizing a condition, and it's not necessarily the best way to view or help a problem. So this raises questions regarding when the characterization of a condition as medical should dominate over other forms of characterization. So in the same book that I referenced earlier, Dr. Santos describes the case of an immigrant from Central Africa who had seen 4 different healers in the UK for persistent throat discomfort and frequent explosive exhalations, and otolaryngologist, a neurologist, a psychiatrist, and a priest. And it was eventually the priest who had successfully healed him by administering holy water, where the specialist had failed to bring about any relief. And I think I think it's a striking example of the sort of situation where we can be blinded by the framework within which we are working, and we may not take into account what the person who is experiencing the symptoms might really be looking for, and what sort of thing might bring about relief, because we can only think within a certain framework. And this brings up the question of when should we be restricted to operating just within that framework? Another thing is that the space for pluralism is constrained by the facts at hand. So, for example, in the case of a malignant tumor, the facts at hand severely constrain possible explanations, because any explanation would have to take into account the presence of the malignant tumor itself. But even then, disorder attribution is not simply a given. So, for example, Ivana Lich, who's the author of Medical Nemesis, he criticized medicine with the same sort of passion and intensity as you can say various anti-psychiatry authors have criticized psychiatry. So after his death in 2002, an obituary in London Independent reported that when he was diagnosed with cancer in 1983, he refused all treatment as the tumor on his cheek became more prominent and painful, and he started subjecting him to epileptic attacks. He refused to accept the diagnosis imposed by the doctors, saying, "I'm not ill. It's not an illness," he declared. "It is something completely different, a very complicated relationship." Illich could accept the physiological reality of the tumor, the reality of the uncontrolled cellular proliferation and the resulting death, while denying the conceptual characterization of it as an illness because of his unique and extreme embrace of the art of suffering. This is a position that is not shared by the vast majority of people. Hence, for practical purposes, the characterization of malignancy as a disease is basically uncontested. However, in the realm of psychiatry, there are far less facts at hand to constrain possible disagreements, and there's much more diversity in the values that people hold. Switching that to briefly about standpoint epistemology, recognizing the historically contingent and folk psychological nature of our domain of medicalized distress, debility, harm, etc., brings up the need for continuous and ongoing examination of our folk psychological judgments, the biases and social forces to which they are subject, and an ongoing dialogue with society and with those we classify. We cannot simply ignore the social situatedness of our medical psychiatric judgments and the ways in which patient service users have been denied epistemic authority and opportunities to participate in the production of medical and psychiatric knowledge. And so, our current boundary, this domain of historically contingent medicalization, requires constant negotiation between multiple standpoints. And any justification that does not take into account the standpoint of individuals with lived experience in any meaningful way is deficient for that reason. Recently, I was reading a bit about the work of the philosopher Robert Brandom, who has certainly who has been working on reviving certain Hegelian ideas within the context of analytic philosophy. And there were there were certain portions of what Gleason was describing about Brandom's philosophy that really resonated with me, and they fit in with some of the themes that I've been talking about. So I'm gonna read some of that regarding this description of Robert Brandom's philosophy. So it's written, communities play a key role. Through the play of giving reasons and asking for them, a social process institutes the normative conditions we might later take for granted, or defines contests that we might expect to be settled. Both Brandom and Rorty have done their best to provide an account of meaning that can survive Seller's thoroughgoing attack on the very foundations of thought. Without any melodrama, the context can be described as a crisis of reason. If there are no truly reliable points of fact, how can we present our thinking in ways that do more than express our personal sensibilities? Many contemporary thinkers are convinced that this is impossible, that each perspective outline expresses only the interests of a particular standpoint, and that any argument, however delicate, can ultimately only be a self-concerned power play. Brandam's response to this sort of like corrosive skepticism is that we are obliged to make sense of the world, and we have no given that we can depend on across every context. But we are never left attempting this alone. Reasons both arise from communities and are appeals to them. And I think along similar lines, I think, there's an analogy to be made here, in the context of my argument. We are obliged to make sense of the domain of psychiatric and sort of like medical distress, disability, risk, harm. And we don't have any universal givens, in the form of disorder or disease concepts to fall back on to provide us with foundational truth. But there are legitimate reasons for medicine and sort of like psychology and social work and service users to tackle this domain with the tools these communities have at their disposals. And these reasons arise from and are justified by the norms of the medical community, what it has to offer, the particular history in which it exists, and the relationships it has with other communities. And that I see as the providing sort of like a justification and the providing legitimacy rather than any simplistic notions of disease or disorder concept. And just three sort of like, I'll make three minor clarifications before I wrap this up. And just for the purpose of explicating my view. So one is that you can ask, if we don't rely on sort of like on a disorder concept or a disease concept as setting a limit on medicalization, doesn't it open the doors for medicalization of anything and everything? And the answer is like yes and no. And and here we have to remember the difference between what can be conceivably medicalized in any possible world, in any possible history, versus what should be medicalized here and now. So the crucial emphasis comes on what is the justification for doing that. And the justification also has to take into account alternative positions, like why medicine? Why not clinical psychology? Why not social work? Why not peer support? Why not pastors? And again, sort of like the how sort of like these professional identities are maintained and distinct from each other is a matter of kind of like how these sort of like disciplines negotiate with each other. So this opens the door for expansion, yes, conceivably, but also for contraction, because I do think a lot of what medicine has been doing is not sort of like well justified. It's certainly failing to do a lot of things that it sort of like it tries to do. And given that failure of medicine, there's certainly, I think, a good reason to be made for contracting this domain rather than expanding further. Am I saying that disorders are what psychiatrists decide to treat? Yes and no. Again, in a practical sense, yes, in the same sort of sense as science is what scientists do, but the justification does not come from a decision to treat. It's not the decision itself that is vital. It comes from the reasons behind those decisions. And those reasons can be analyzed, and those reasons can be erroneous. They could be mistaken. They could be prejudiced. They could be unreasonable. They could be all of those things. So this is not some relativistic thing where an arbitrary decision to treat becomes the justification by itself. And then the final thing is that we cannot step outside the history in which we exist. We cannot redraw and renegotiate these boundaries from scratch. We can certainly redraw and negotiate them from where we stand right now, but we can't imagine that we are existing in some alternate history when in fact we are not. Our beginning point has to be our present historically contingent domain of medicalized harm and risk. And we have to ask, what would constitute good reasons for us to expand or contract the boundaries we currently encounter? And how should medicine negotiate these boundaries with other disciplines? So with that, I'll sort of like I'll end the formal sort of like component of this talk, and we can open this up for question and answers. And this is my email address. Anyone is welcome to reach out to me with ideas, questions, and I'll be happy to address them. Thank you.
Thank you very much, Awais, Aftab. Thank you for this talk. We're now gonna take your questions. So please, if you can, write in the chat that you have a question, and Marie and I will be able to follow them in order. So you can just write, I have a question, something like that in the chat. Okay, so let's start with Jonathan Tsu.
Hi, Awais. Really rich paper. I really like this. So I have a lot of questions. So I guess one of the general comments I have about your paper is that, so you can correct me on this if I'm wrong, is that you're really focusing on clinical concepts or the way that concepts might operate in clinical contexts. So one of the feelings I had in this was that you might not be giving enough weight to the research side of this. So as you know, I think the concept of disorder, it's not dispensable. My preferred way of thinking about them is as natural kinds. And for me, it's basically one of those reasons you gave, right? I think one of the things we want to rule out trying to treat in treatment context is something like artificial kinds, like drapetomania, homosexuality, things that have historically been put in the DSM. And so if I understand what you're saying, so in your rejection of the kind of these global kind of concepts of disorder, you're taking something like a particularist approach. So you're saying, well, let's just look at the particular things that we treat and look at the negotiation between different kinds of fields that are trying to treat these kinds of, whatever you want to call them, things, conditions. And that kind of negotiation will be more important for justifying whether these are kind of legitimate kinds of conditions to be treated. And so I guess one of my questions is, well, my feeling is when your mode of justification goes that way, I think ultimately you're going to have to fall back on some of these traditional demarcation problems, right? Like natural kinds or biological dysfunction, something like this. So for example, I think ADHD, this is a good example. So there's a lot of contested concepts you might want to bring into your discussion. So ADHD, scholars have argued this is a kind of socially constituted disease insofar as it's very closely correlated with more faster paced societies. Something like this came about largely with industrialization. My own view is there's biological mechanisms behind attention behind this, but it's probably not its own specific kind of condition. It's tracking something. So I think it's a natural kind in some kind of sense, but attention, ADHD is a kind of distinctive kind of dysfunctional disorder that doesn't seem to be right. And so that tracks on to kind of the questions you're interested in, because, obviously one of the main kind of interventions that's appealed to is Adderall prescription now, right? We're giving stimulants to kids basically at a very young age. And so I'm just throwing a lot out. I should put this in the form of a question. I would say, doesn't your approach, isn't it ultimately going to appeal to some of these kinds of traditional issues that are raised more in kind of research context? And I guess, how would we prevent the kind of reification of kind of artificial kinds? Because I think there's a lot of, and there I think the harm condition has to be very, very important, right? Like,
right, yeah.
Yeah.
So let me try to address that. So one thing is that, I do think, whatever sort of like condition sort of like we take on, like we would have to understand like what are the etiological sort of like mechanisms of that. I know at what sort of like at this point, a lot of it is basically like unknown or speculative, which sort of like don't know, but determining those sort of like etiological sort of like mechanisms, processes is definitely going to be a part of that. And sort of like the more we sort of like determine sort of like what those mechanisms are, the more sort of like that will constrict the space for like what explanatory perspectives can account for those mechanisms, right? So if it turns out that sort of like, that certain conditions are sort of like do have like certain like neurobiological dysfunction, well and good, sort of like that'll change our understanding of things. But if it turns out that there isn't sort of like, an identifiable neurobiological dysfunction, there's like some other kind of psychological dysfunction, but we still do have sort of like effective treatment. So let's say it turns out that there's sort of like a subtype of ADHD that is not a natural kind, just hypothetically, it's not a natural kind, but they respond just as well to stimulants, right? So like, would we use that demarcation as like, oh, this is not a neurobiological dysfunction, so we are thereby excluding this from the domain of medicalization? I don't think this is how medicine works, and I don't think this is sort of like that kind of thing operates. Same thing with like depression. Like, let's say sort of like, some people, obviously we know that not every depression is going to be a natural kind, but the question is, how do they respond to treatment? And if they respond well to the sort of treatment you have to offer, from a clinical perspective, the question of natural kind is moot, right? And so that's one thing. Then second, I do think there's a difference between like research setting and clinical setting, and I think they draw on different sorts of justifications. And in one way, I think you can sort of like see them as like research, especially if it's into conditions that are not formally recognized already in clinical settings as disorders, is that research is trying to sort of like uncover justifications for whether something could legitimately be medicalized, or or sort of like psychologized, whatever. And if they're able to sort of like determine that, then that condition shifts from sort of like this investigational mode into something that is formally recognized within clinical domain. So example would be like mild cognitive impairment, sort of like that it's not sort of like it's cognitive impairment that is not to the degree that you see in dementia. It was being researched for many sort of like for quite some decades, and then in recent sort of like 10-15 years, it became formally incorporated as become a disorder of its own thing. So we can think of research and sort of like clinical domain as being different stages of this sort of justification, with sort of like some different sort of like emphasis on different sorts of norms.
Thank you. Next question is from Scott Waterman.
Yeah, excuse me. Thank you. Yeah, thanks, Awais. That was very enlightening and enjoyable. As I think you know, I'm in an enthusiastic agreement with your overall thrust on this, but I do have some difficulty grasping how to, and obviously you do too, and as we all do, how to operationalize this notion of whether or not medicine has something to offer. And one memory that came to me while you were talking from when I was a little kid, my father was a pediatrician, and I was remembering that for some period of time, there was a mother of a patient who would call our house every morning and ask him what he thought in the context of the weather forecast that day and various things along those lines, what he thought she should clothe her school-age daughter in for that day. And I know that for some period of time, he would try to empower her to make that decision. He would, in some sense, not in these words, I'm sure, disavow any particular jurisdiction, as it were, over that decision based on the fact that he was a physician. What to clothe your child in is presumably outside the domain of medical expertise, but she wouldn't have any of that. And I think eventually he simply gave in and realized the path of least resistance would be to say, I think maybe a sweater and carry a jacket. Okay, talk to you tomorrow. So the question of whether medicine has something to offer isn't necessarily ours to decide. And another question, a more academic one, relates to this very interesting notion of medically unexplained, which has intrigued me for a very long time. That is to say, what one means by that. It's always struck me as sort of question begging, and I'm looking for your take on this, which is to say, what counts as a medical explanation? In one context, suppose someone with hallucinations comes to a psychiatric clinic. Under those conditions, one would be tempted to say, and probably would, that a diagnosis of schizophrenia explains the hallucination. Of course, we don't know what causes schizophrenia, so all that means is that it is somehow syndromically coherent. On the other hand, a patient going to a gastroenterology clinic with abdominal pain that proves not to be explained by, say, blood tests, radiographs, and endoscopic examinations, the gastroenterologist might conclude that anxiety is the explanation, but that, even though that would also be syndromically coherent in some sense, would be said to be a medically unexplained symptom. So that doesn't really get us anywhere. So the generic point, I guess, behind these two different anecdotes is, how do you get your hands around how to determine what medicine has to offer, either in an explanatory or a therapeutic sense?
Yeah, no, both of these are like really good questions. So the one is sort of like, regarding the first question, I would say that this is a sort of like, I think this is a determination that happens sort of like, within a certain social context. So they're sort of like people in the community, people in society have certain needs, and they look to sort of like to someone to be able to like address them, or sort of like to sort of like provide some sort of to relief. So it's definitely not something that any profession is sort of like is able to decide unilaterally on their own. Rather, it's something that happens in broader negotiation with society.
Right.
One issue is that sort of like I think historically our emphasis on sort of like in this debate has been on determining some sort of idea of disorder. Like, we have been so focused on debating this notion of disorder that we haven't really sort of like tackled the notion of like like legitimacy and justification by itself. So I think one thing we can probably do is that sort of like give up this myopic focus on this question of, is it a disorder, and sort of like and think about sort of this larger set of questions of like what can we do and what do we have at our disposal. And the thing, and once we sort of like once we start asking this question of what do we have to offer, it inevitably sort of like becomes sort of like the issue of like, it's not just like medicine, but like what are the players that are active in this area. So for example, like if you go back sort of like in the asylum era, like clinical psychology didn't exist, like social work didn't exist. It was basically physicians as a group who had some sort of scientific credibility behind them, or it was like various sorts of healers. So if you looked at some sort of a scientific approach to treating lunacy or madness, medicine was basically the only game in town because nothing else existed. So by default, any of those problems kind of like became medical. Right. Mm-hmm. And this started changing, for example, like, in the 20th century. So even in the beginning of 20th century, psychology existed, but it existed only as a research profession. Like, psychologists were not clinicians. So in the first half of the 20th century, any sort of psychological problem that emerged and someone needed practical help with that, medicine was basically the only game in town. It started changing in the sort of the second half of the 20th century, where now clinical psychology is also in sort of like they're also active clinicians, and it's beginning to sort of like change even more, where we have sort of like peer support services by the sort of like service users. We have social workers maybe asserting the independent identity. So now the question is very different, because previously it was just one game in town, but now we have a lot more options. So how can we divorce the question of what we have to offer from the question of like what these other professions have to offer, and sort of like, and how to sort of like negotiate sort of like and what sort of like and what sort of like perspective might get dominance in any particular case. And because we have been so focused on this disorder notion, we have really not paid attention to this sort of larger, more messier question of how that negotiation should take place, when in fact it's happening anyway, whether we like it or not. Even if we choose to focus on the disorder concept, that negotiation is happening. The second question regarding medically unexplained, I won't go in like too much sort of like in depth, because it's just like it opens a whole other Pandora's box. But I think my sort of like I think there are two sort of like approaches people take to that. Like, one is like whether we can identify any sort of like specific sort of cause, especially some sort of like neuropathological cause of something or not. So one is the causation kind of thing, that is the symptom or presentation I'm seeing, does it have any specific etiology I can determine? But then the second thing people also do is that whether the symptom fits in with any of the well-recognized identifiable syndromes or conditions that I know of. So for example, in the past, congestive heart failure, even if we didn't know exactly the etiology of that, or if we didn't exactly know what was, causing the heart failure, like heart failure as a syndrome was identifiable, and you could determine that one patient who is having dyspnea, sort of like whether that dyspnea fits in with this sort of syndrome or not. And so in the case of psychiatry, sort of like if someone comes in with hallucinations and you see that, well, they also have delusions and there's this history of functional decline over the last year. And so you can say, well, this seems to like fit in with like a more schizophrenia kind of like syndrome. But let's say someone comes in with sort of like reporting voices, but they have nothing else and nothing else going on. And now you have a situation where you have a symptom that fits in with no identifiable syndromes that we have available to us. And that might be considered a sort of medically unexplained thing. And a corresponding thing in like cardiology would be, or like, let's say like pulmonology would be, someone comes in with a cough and you do everything sort of like, you do a good history, and the cough is not part of any recognizable syndrome, nor you can figure out what's causing it. And then you sort of like, you call it medically unexplained. So that's how I think what happens in practice is that people are thinking in terms of causes, but they're also thinking in terms of identifiable syndromes.
Thank you. So next question is from Miriam Solomon.
I enjoyed your talk very much. I'm very sympathetic with the sense that the word disease, disorder, are not doing much work for us. I think I once mentioned to you that John Worrell's work is very sympathetic to this. I'm also thinking that Quill Kukla has some kind of definition of disease going that's defined in terms of what medicine can offer. It's more general than psychiatry, but it's maybe related to what you're doing. What I particularly appreciated was the end of your talk, where you tried to say, this doesn't mean we give up on the space of reasons. This doesn't mean there are no good and bad reasons for medicalizing it. It's not just a sociological answer. And so I kind of would like to push you on that and see how you would handle the observation that you made that psychology fits rather strangely into medicine, or it's uncomfortable in medicine. Clinical psychology has an uncomfortable place in medicine. You said something like that. Yeah. And I'm thinking about it and I'm wondering, well, yeah, there are extremely good reasons for thinking that they don't belong in medicine, given the tools that they learn. You don't really need to learn anatomy to do cognitive behavioral therapy and so on. But if they did move out of medicine, then they probably would have trouble getting reimbursement. That's why they're in medicine. They're in medicine because it makes financial sense for them to be in medicine, because that's where the money and the power are. Now, is that a reason? Or is that more like a social force? So what gets to count as a reason?
Yeah, that's a very good question, and I don't think I'll be able to like do sort of like any sort of like proper justice to this, like within the short sort of like short time period that I have. But I do think there's I think a distinction to be made between sort of like what we would consider to be legitimate in terms of sort of like reason, and versus sort of like what we would consider to be simply some sort of a restraint being imposed by sort of like by practical considerations or the setup that we're working in. So the issue of when we sort of like talk about like reimbursement, so our sort of like we're kind of like limited by this idea. The general societal notion is we're only going to spend like money on something if we think it's a disorder, if we sort of like, if we think it's a disorder in some sense, and so that's sort of like, that's the constraint that has been imposed on us by the government, or like by the insurance companies. And that sort of like, restraint has in fact contributed to a great deal on expanding this category, because everyone is sort of like trying to push this sort of like, push this category and show that these problems are in fact disorders, so that they can be reimbursed for that. So, that's a practical consideration, but like what sense does it make on philosophical grounds or scientific grounds? And if you sort of like begin to analyze that, it really doesn't, right? So there are sort of like, many ways you can criticize sort of like, that, and we can sort of like see that it's historically uninformed by sort of like these this sort of like this focus on this idea of disorder and it's that. So I think once we recognize that, once we sort of like see the context of sort of like what that reason or what that is, I think that gives us clues regarding whether we begin to question that, or whether we accept that as something more legitimate or not. I mean, I think something more like, let's say, scientifically grounded would be things like efficacy of medication, or like response to psychotherapy. Like, that's something that like science can kind of outline, like if you treat this sort of presentation with this sort of medication or this sort of like, psychotherapy, like what sort of success do you get? And so those would constitute reasons that we can kind of elaborate more clearly, or various sorts of harms. We can sort of like study that if we treat a particular problem with this sort of approach, do we end up hurting people more than helping them, right? So that's a question we can analyze more. But I think with questions like social arrangements, they can sort of like reasonably be questioned and challenged once we understand the rationale of what we're trying to do. So that would be a preliminary approach, but I do think I would have to flesh that out more.
That's a great answer, and I just want to add a small point, which is that the current dean of med school at Temple has a big effort going on anti-gun violence, and she regards it as part of medicine that she do this. She's a trauma surgeon, but I can see that it might not qualify if we need reasons, because after all, she's not somebody who really understands the social dynamics of gun violence or so on. She could lend her name, but why is she doing this? Would that be the sort of thing you would comment on?
I think it definitely, I think it's sort of like, I think it's within this framework that we can discuss. I think it's a bit more sort of like, I think, complex issue, because because then we sort of like enter like the territory of public health, and sort of like there's this like public health itself has a complicated relationship with medicine, and there's this question of like, to what extent is public health medicine or is it not? And so I would say that there's this negotiation between the public health community and medicine as well that is ongoing, and that forms the background of that. So that's what I would think, at least in the beginning.
Thank you. We're going to take the next question from Jake Jackson.
Okay. Thanks, Awais. So my question sort of follows up from the line of questions that have been going through. Part of the issue, or like part of the concern I see is that disorder in and of itself, or like the term disorder, also sort of imports these sort of social concerns, right? Or like social disorder is also like a sort of almost hand in hand, almost in like the Foucauldian sense, right? Of talking about like social deviance or like unreason, etc. And it's something where I'm very sympathetic to the notion of pluralism, or rather, I think that the only clear path that we have in terms of understanding disorder has to be a pluralistic one. But then I worry as well about the fact that this sort of the fact that psychiatry as a medical practice, or psychiatry as like a social science, etc., can't give a definitive answer as to what disorder is something that is oftentimes taken advantage of by other groups, right? So the anti-psychiatrists, the critical psychiatrists, the Church of Scientology, like every other huckster that exists in terms of like trying to carve out a niche and say, oh, no, you can't trust psychiatry because they don't even know what a disorder is, or something like that. So maybe more, my question is what do you see as a way of positively constructing pluralism, or positively communicating the need for pluralism, in the sense that it seems that something that would be ideal out of your model of what a disorder, or like the domains of a disorder is something that requires psychiatrists to collaborate with other fields, or sort of admit some sort of sense of humility. Otherwise, there's this fear that or like what the current state of things is almost this chaotic, anything goes type situation.
Yeah, no, this is another sort of like very, very excellent point and excellent question. So one thing I would say, I think this historical emphasis on determining what is a disorder, I think, has really hurt the debate in a very negative way, because so much energy has been focused on this particular question, like both by people criticizing it and sort of like both by people defending that, and I think it helps when it sort of like, again, we shift away from that narrow question and think in terms of what are the justifications and what is the space of reasons. And I think, and once we do that, I think it's very natural that it immediately becomes a sort of like pluralistic issue, because we have different communities, and we have different communities with different sort of like norms, and we have different sort of like sort of like competing or sort of like or complementing reasons sort of like for approaching that. So from my perspective, I think as soon as we recognize that the disorder concept is not foundational in any way, but there are independent legitimate reasons, and we start to sort of like talk about what those reasons are, it's inevitable that we have to sort of like engage in this sort of like pluralistic kind of negotiation between different perspectives and different communities and different norms. And I think that has to be sort of like the beginning point, and currently we don't see that happening. Sort of like again, that's why I mentioned the British Ecological Society reports, and what do they? I mean, so I think in some ways that they're trying to do something quite, I think, meaningful, that they're trying to sort of like create like perspectives on understanding these conditions that are non-medical. They want to try to understand depression in a non-medical way. They want to try to understand psychosis in a non-medical way. But what they end up doing is that they end up sort of like, oh, this is not a disease and this is experience. And so, it ends up sort of like being framed in these sort of like these rather superficial terminological and conceptual issues, when we could more meaningfully have a discourse on what do we have to offer and sort of like what are we doing. And I think if we begin to do that, I think we have there's a lot more productive potential for debate like this.
Great, thank you. Next question from Bennett Knox.
Hi, thanks so much for the talk. Just fantastic. I think I'm broadly in agreement with pretty much everything you have to say. My question is sort of, I guess, a follow-up on those last two also, because I do have a sort of similar residual worry that if we let go of the idea of disorder in sort of, let me frame it this way, there's like sort of two senses of conferring legitimacy on medicine or medical psychiatry. There's sort of the work that, we philosophers and psychiatrists themselves do to try to like determine what actually does confer legitimacy to medicine. And then there's sort of like the more communication and practical problem of like, okay, how do we like get society to, and particularly policymakers, to sort of view psychiatric science as legitimate in a way where they'll prioritize conferring resources onto it. And I think in the sort of first project, I'm like way on board. Like, yes, we need to expand beyond this concept of disorder. We need to, have more the type of discussion that you're talking about. But the worry is that like, if we let go of this focus on disorder in that domain, it's going to spill over into sort of like the policymakers who are not having kind of, consistent rational discussions about these sorts of things and are just deciding where to throw money or not. And if they see the psychiatrists saying, oh, well, maybe we're not really talking about disorders, then they're going to say, okay, well, let's slash mental health care funding, or let's, view these as moral problems and throw people in jail. And there'll be those sorts of like practical ramifications that I think we all want to avoid.
Right. No, and this is a sort of like very excellent sort of like legitimate point, an excellent point, and I this is definitely, I think, something. It's a challenge, and I want to draw in an analogy here with philosophy of science. So if you look at sort of like the public notion of sort of like, you know, what the science and the scientific process is, sort of like they think, oh, this is like very objective, and sort of like, you know, you somehow sort of like uncover sort of like, you know, the objective truths out there, and sort of like science provides us with sort of like, you know, some sort of unfiltered access, and we kind of like, you know, there's sort of like a crude version of like, you can say like correspondence theory, where you kind of like, you know, sort of like reach out and sort of like grasp the facts themselves. And sort of like, and what sort of like a lot of sort of like philosophers of science, you know, in recent decades, especially during the great science wars, have shown is that sort of idea of science is like very simplistic, in fact inaccurate. Like science has no direct evidence to any sort of like objective facts like that. Sort of like, you know, it's a very social process by itself, and through kind of like variety of sort of like experiments and methodologies and things like that, we are able to justify theory. We were able to come up with theories that provide the best explanations for what we are seeing right now. But at the same time, these theories are always fallible. They might always be wrong. They might be subject to revision, right? But you know, it's a challenge. Like, how do you communicate to the public without them losing any trust in science? Because if they think of science as a sociological process where it's not as objective as people think it is, then it's just like, well, anything goes, and why believe anything? And I think we saw some of this happening during the COVID-19 pandemic as well, as we saw the peer review process happening in live, sort of like, you know, live, and sort of like with findings, preliminary findings coming out and being revised and being challenged. And when the public saw that, sort of like, you know, I think a big reaction was like shock and mistrust, and sort of like, you know, some people were like, why believe anything? And so I feel like, you know, psychiatry has kind of like a similar problem, where if we want to be philosophically accurate and we recognize sort of like what's really what the real dynamics of these concepts and sort of like things are, we then have to contend with the public image of what they want what they want medicine to be, and what they want psychiatry to be, and what they want science to be. And so I think it's a challenge that I think that affects psychiatry, it affects medicine, and I think it affects all of science. And I don't think I have a good answer for that, but I do want to recognize that this is a challenge, and I think all scientific fields are struggling with that.
Thank you. The next question is a written question in the chat from Murray, so I'm going to read it. Can medicine focus on suffering, harm, and risk without taking into account concepts like function, social normality, intelligibility, etc.? If not, what are the barriers?
I think I don't think we can simply give up those sorts of notions. And I think what they primarily do is that they serve as offering some sort of an explanation into the nature of sort of like suffering and risk. So it's not sort of like simply, from my perspective, not simply enough to sort of like point out to instances of suffering and risk and say that, oh, like, you know, there is suffering here, therefore we must like intervene. But it also sort of like, there's this question of like, you know, to what extent can medicine understand the nature of this suffering, or the nature of this impairment? And it's, you know, it's really impossible to do that without sort of like, you know, utilizing sort of like these broad notions of things like, you know, functioning and sort of like in social normativity and intelligibility and things like that. So I think they come into sort of like play as sort of like as providing one sort of like, you know, different conceptual tools with which we identify the nature of suffering or impairment, and therefore they're sort of like, you know, but there's no single essence that I think that determines like what that approach is going to be look like. So, you know, the notion of function may be relevant in sort of like, you know, in certain sorts of conditions of suffering and certain sorts of conditions, but it might not be in other, and where there are other concepts might play a role. So I think this sort of like these sorts of concepts are important, and I think they're inevitable, but I don't think there is one concept that by itself takes precedence over the other ones. I hope that helps kind of like answer what you were trying to get at.
Thank you. So next question, I think we have two remaining, would be from Octavio Federico Garcia Villagomez.
Hello.
Yep.
Hi.
Hi. Well, for me, disorder, a difference of the disease, the disorder can be related to any specific abnormality of target. If you have diabetes, you can say has a disorder in the insulin glucose response. If you have hypertension, you can say there is an increase in the pressure of blood of the vessels. I mean, you know the cause a priori or a posteriori. But if you have depression, you cannot say you have a deficit of serotonin or an alteration of any transporter or receptor. Can be any place in the system. Can be serotonin or dopamine or melatonin or any other substance. The truth is we don't know much about the a priori causes of mental disorders. I think the problem related to psychiatry has to be with the measurability of or object of study. We cannot measure depression or anxiety or obsession or delusions in the same way as the cardiologists do it with the heart. That's true. It's a problem of the positivism and the scientific method. But well, there is the phenomenology and also the subjective and objective functionality as measures. What we cannot do is go to the scene of measurable psychiatry, like a kind of sensiology that can tell us the measures of the spirit, of the levels of energy, or that kind of things that are related with the scientificism of the more radical postures of positivism. But also we can go to the extreme of the structuralism and say that the reality is just a social construct and think that the world is like a matrix or a demonic possession, or this case of Illich that you describe and its peculiarity, no? I think there are phenomena. There is a great story of semiology and phenomenology in the process of description of psychiatric disorders. We have Kraepelin, Clérambault, Jaspers, Lawler. Certainly there are disorders more controversial than others, but what we must do is continue doing a semiology of the manifestation of the mental disorders and document the response of our treatments to make the psychiatry a science, a true science.
Yeah. So Octavio, may I interrupt you at this point, just so that we can sort of like, have some time for one or two more questions too. So in regard to your question, I think my brief sort of like response would be that I think psychiatry sort of like, refers to conditions at a different level of explanation. So for example, like, if you're talking about hypertension, we're sort of like describing the condition in terms of sort of like variation in blood pressure. So that's a level of description we have at that time, even though we have no idea what's causing it. Like, we don't know why even though we may not know why one person has high blood pressure than another, but that's a level of description. I think psychiatry's level of description is just different in that we're dealing with like more sort of like, psychology and phenomenology. So I don't think that there's like that sort of fundamental difference between describing depression and describing blood pressure. I think it's just a difference of what level we're using to describe something. But I don't think that necessarily by itself sort of like settles the issue, because I think, again, sort of like the issue is what can we do about it? And sort of like, and what are we trying to do with blood? In the case of blood pressure, we want to reduce the risk of subsequent cardiovascular events, and we can intervene on that using hypertensive medications. And in the case of depression, we can sort of like, intervene using psychotherapy or sort of like antidepressant medications and do that. So I think it's those sort of what we can do about it that really, I think, settle the question of is this a legitimate medical condition or not, rather than these, I think, considerations of causes are not. But I appreciate sort of like what you were saying.
Thank you. I think we're actually already a bit out of time, so maybe we can take a brief last question, and then I would invite everyone to maybe as you invite people to do so if they have further questions.
Yeah, anyone can email me, and I can type out my email address in the chat as well. Yeah, anyone is sort of like welcome to reach out to me. I would greatly appreciate that. And yes, I think if we can take a brief last question, that would be helpful.
Yes, sorry, my internet connection was not working. Anne-Marie, did you get if like?
No, I haven't talked.
Okay, I guess we can just I guess we can wrap it up at this point then. And so anyone has any further questions,
so thank you.
They can just email me, and I will engage. I will respond.
Great. Okay, thank you very much, our speaker today, Awais Aftab. Very interesting talk. I invite everyone to be there in 2 weeks for our next session. The talk will be given by John Greenwood, and he will talk about etiology, distress and disability, and dysfunction in DSM-3/5. So thank you everyone for coming, and don't forget to register for the next session.
Thank you. Bye.
Thank you very much. Bye-bye.